Welcome to this webinar hosted by Respecting Choices with the purpose of sharing the experiences and challenges of teams that are working to continue to meet the needs and provide the benefits of advanced care planning during a time when physical distancing has created a need to adapt on many fronts. I'm Carol Montgomery, and I'm the Executive Medical Director for Respecting Choices, and we'll be facilitating this webinar and want to introduce you to the other three panelists, all of whom are experienced advanced care planning leaders. First is Bonnie Bizzle, who is the Community Education Liaison and Program Manager at Honoring Choices Pacific Northwest. Sandy Schellinger, who is a palliative care nurse practitioner at Livio Health. And Chris Brinneman, who's the Advanced Care Planning Manager at Parkview Health. And I'll ask each of them to introduce themselves in the context of their work in a little bit. But first, I thought it would be helpful to sort of describe the circumstances of what caused this webinar to come to be. And that is that because of the pandemic, as you all know, it's created a need to adapt many aspects of advanced care planning. And while it's important to affirm that the nature and content of an ACP conversation itself remains unchanged, there are clearly communication skills, strategies, and workflows that become important when adapting for telephonic or video or some combination thereof of remote advanced care planning. And so we really thought it would be a good opportunity to compile what we've heard and observed on this topic from our virtual office hours, from our facilitator calls, from working with teams. And in listening to those experiences, it seemed like the things sort of fell in three themes or buckets in the way of sort of organizing my thinking anyway about all the adaptation that can benefit those we serve. First is what adaptations are beneficial when thinking about how to go about inviting people into a conversation and how to really prepare for having a remote conversation, so sort of the pre-planning. Next is how to start a conversation and actually have a remote conversation and what's different in the midst of that. And then third is in following up after the call, what needs to be different to make sure that the rich content of the conversation is memorialized in a way that can live on across locations and time. So I guess with that, Bonnie, can you kick us off and tell us a little bit more about your role in your organization and what you have learned about how to really prepare for a remote ACP that might be different and how you've shared those strategies with your teams?
Great, thank you so much. Yeah, happy to be here. So again, I'm Bonnie Gazelle. I'm with Honoring Choices Pacific Northwest. We are a joint initiative between the Washington State Hospital Association and the Washington State Medical Association. And so what we really do is we act as a convener. We have a lot of program partners that we help train and we support, but we primarily act as a convener. We do also provide direct services, but our primary purpose is to help other organizations embed and engage in the work of advanced care planning. And so when we came to this conversation about advanced care planning in the time of COVID and sort of the need for remote advanced care planning, we were really thinking about it from a convener perspective and sort of how do we help our partners be able to do this well and feel confident and competent and able to do that. So we happen to have monthly meetings or monthly training webinars where we have all of our program partners, anyone who's been trained with us can get on and we learn. And we took one of those early on. We took the March one and we said, what do you need from us? What will help you most? And they overwhelmingly said, we need help in knowing how to do this. We also offered to provide direct services for them if they felt overwhelmed, as a lot of our partners are healthcare organizations, and so many of the resources were being moved, and just to let them know that we would help fill in, we would backfill that for them if we needed to. So what we did is we took time and put together 4 boot camps. Basically to help sort of train folks immediately and get them the information they needed. And that was around sort of an overview. We created this tip sheets, an overview view sheet that helped him see the different ways and opportunities, but we also dove deeper. And we covered sort of all the opportunities out there. There are a lot of opportunities for virtual engagement once you start looking for them. And we dug into specifically around how do you do it on the telephone? How do you make a live presentation via Zoom or Facebook Live or YouTube? And then we also looked at texting. How do you message? How do you use that to support? And so what we wanted people to know first and foremost is that, hey, you've already been trained in this. A lot of the skills that you already have apply in this situation, and you just need to really lean into those skills, because ultimately we want the conversation to have the same characteristics, I'm sorry, the same things as if they're in person or if they're remote. So we want them to be individualized in honoring that person's current health and story. We want them to be informative. We want those opportunities for teach back and learning. We need them to be engaging so that the individual and their loved ones or whoever matters to them, if they're present, are all participating. And most importantly, it needs to be safe and a place where people can explore these sensitive topics in a supportive way. And so, you know, those skills that we already have in training with respecting choices, that exploring, that clarifying, summarizing, empathy, empathizing, and reaffirming the purpose of having the conversations, those still exist. Nothing about that has changed. But what we found is that there were an additional four, what we call the 4 Ps. So instead of minding your Ps and Qs, you mind your Ps and Ps. And those 4 Ps really sort of dig into what's needed in a remote or virtual session. And that is first, politeness. That's the first P. You know, not only just being on time, but it also means assuming the best of others. You know, nobody wants to come to this assuming negativity anyway, but really knowing that people are trying their best in a very difficult time. Clearly apologizing for any error to help build up that trust and comfort. And I say this knowing that sometimes we apologize, we'll need to apologize for something that we don't think is an error. And that's because it's not about us, it's not about intent, it's about impact. And what is your impact? And if your impact created a problem or an issue or discomfort, you need to apologize for that. And you need to understand that you need to be polite even though you're at different spaces and at different times. So that's the first one, just being polite. The second one is patience. It's really expanding your capacity for being patient for another person. So you might have to wait longer for replies, not only when you're trying to schedule stuff, but in the conversation itself. I personally count to 10. So if I ask a question, I sit there and I mentally count to 10 to make sure that I'm not jumping in too fast. And when you're setting up those meetings and times together, that you really are also setting up expectations. Here's what you can expect from me. And it's also, patience is also about recognizing that the environment might be interrupted. We're so used to being able to host people in spaces that we control, that we need to understand that we have let go of that control. And what does that look like? That means that there might be a dog barking in the background. There might be a child who needs immediate assistance. There may be that need to jump off. And I think if we realize that and there was a recent BBC interview where a mother, her child came and started talking to the BBC interviewer, and the BBC interviewer was like, you know, I like that unicorn picture. I think we need to recognize that we need to have patience with whatever space people bring with them to these conversations. And it also means realizing that, hey, the conversation may not go as I planned, just like that BBC interviewer. You might get off track. You might find things are more emotional or more in depth or just different than you expected. And just sort of recentering yourself in that's okay. And lean into that because you've already been trained for that. So politeness and patience. The third P is persistence. You're going to have to troubleshoot technology. Everyone on this call had to troubleshoot this recording a couple of times. You're going to have to troubleshoot it. There may be times when words or phrases drop because technology is wonderful, and it also can be absolutely horrifying when you can't hear everything or see the reactions. You might have trouble just connecting one-on-one with a person in the first place. There is a lot of stuff going on in the world right now, and though they may really want to have this conversation, it may take time, and you have to keep asking them, not in a condescending way or a scolding way, but just saying, hey, you know, we talked last week about meeting next week, and it's already next week. I know things change rapidly. How can I support you in this journey? You know, sort of opening that door instead of criticizing the color of the door. And then keep working on solutions. The more you do this, the better you'll get. The more at ease it will become. And you'll be able to create your own best practices and move forward with advanced care planning. And this is not only with the technology that we have to mitigate, but also in those conversations and finding ways to connect, whatever that looks like for you. The fourth one is presence. So we've had politeness, patience, persistence, and now presence. So presence is vital to creating connection. And when we're doing it in person, it's a lot easier to feel like we're actually connecting with someone. So we have to, when we're doing this remotely, take a moment and make sure that we have set it up that we can be absolutely present for the other person. So that may look like, where am I going to do this? Where am I going to do this call? Maybe I need to lock myself in the bathroom because that's the only safe place I know because I'm working at home and I have 3 dogs and I have 2 kids and I have a husband. Maybe for the call, I need to just make sure I'm in the bathroom. Or it could be out in the space. It really sort of depends on what your situation is. But being actually thoughtful about and intentional about how you're going to be present will help make being present easier. You know, make sure that the reminders beforehand and the follow-ups afterwards actually address that person, because that's how we know that you care about us. Is if I know someone's name and I use it, and even though it may be a standardized email, follow-up email, or pre-appointment text, if they've said something to me that I need to highlight, I make sure that I do that whenever possible. And, you know, in the discussion that can also look like, and we'll hear about this more, about checking in more, asking more questions, not just relying on what you may be seeing in the frame, but still following up beyond those visual cues. And on the phone, it's following up even more because you can't see those visual cues, and body language is a huge part of what we do. So those 4 Ps, politeness, patience, persistence, and presence, are things that you can do to sort of ready yourself for the best possible remote conversation you can. And I think it's important to remember that all of these technologies that we have been experimenting with and going out and using now can and should reinforce each other. So I've already talked about like the email follow-up or the pre-appointment text. How can you vary that technology? Because the more you vary the technology and the more you're able to give people the opportunity to really participate in a way they feel comfortable participating, you are hitting more directly at that person-centered approach and really discovering that, hey, you know, most younger folks really don't want to talk on the phone. They just want us to text questions that they can come back and answer. Or maybe the older folks feel more comfortable on the phone or in in a Zoom chat or something.
So that's a really
maybe,
great question, but
yeah.
or comment, Bonnie, or observation is that part of preparing is preparing oneself as a facilitator. And I
Yes.
love sort of the centering of oneself and reminding yourself of the 4 Ps immediately before entering into the space of a conversation. But also as part of the invitation strategy that might need to be adapted is, you know, how do you offer a menu of ways to connect so that you make sure that it meets with whatever that person feels most comfortable with, and not assume because they're younger or older, one particular mode or another will be what they're most comfortable with. And especially since, you know, 80% of communication is nonverbal. And if you're in telephonic without the advantage of video, you really have to cue in on all those other communication skills, and checking in, yet allowing enough silence when you can't see if they're really thinking or if they're just like watching a commercial on TV. I mean, it's really different skills to really think about. So,
and being comfortable with that, right? Being comfortable with like hearing that TV in the background and saying, are they paying attention to me? And letting go of that sort of ego piece and just saying, you know what, they're giving me what they can right now. And that I can honor and work with.
So Sandy and Chris, anything that you'd add to your either invitation strategy or preparation for entering into conversations?
I think you highlighted it.
Go ahead, Chris.
I think you both highlighted the important pieces and really the key piece of, as a facilitator, know where you are, not just your physical place, but bigger than that, as you prepare to have a conversation where you might not be able to make that immediate direct connection because you're not physically present with each other.
Mm-hmm. Sandy?
Yeah, and I guess the only thing I would add is the approach that we take from an advanced care planning perspective, and actually the services and support that we provide is interdisciplinary. And so we do quite a bit of prepping as a team prior to visits. So I think for an advanced care planning visit is, how do you share the advanced care planning conversation? You know, who's going to ask which question? Who feels more comfortable exploring one part of the conversation versus the other? So I think negotiating that's somewhat of the prep that actually helps you be more present, because you know as a team you're going to ask the conversation and have the conversation together versus just one person having the conversation. And I think exploring the questions with different team members will get different results.
Mm-hmm.
So
rounds it out.
Yep.
Nice. So that Bonnie kicked us off with sort of what do we think about before entering in and planning for. So Sandy, can you talk and take us through beginning and having a remote ACP conversation? And when we were sort of preparing for this webinar, I was impressed with the strategies and success you've had in your practice in adapting, sometimes on the fly, with how that works. So if you could share some of your lessons with us.
Certainly. And thank you for having us and letting us share our thoughts. So I am a nurse practitioner, a palliative care nurse practitioner, and I work for Livio Health Group, and we provide supportive in-home palliative care services for people living with serious illness. And our visits can be in-person, telephonic, and telehealth. And we serve individuals who have Blue Cross Blue Shield Medicare Advantage insurance. So it's part of their benefit to receive interdisciplinary palliative care services. And we focus on really trying to meet people where they're at, understanding what's most important for them at the time, and really helping to align their care with their goals and their values. And so the Respecting Choices conversation is very person-centered, and it allows the individual to share their perspective versus us setting an agenda to the visit. So it's just a natural thing for us to use. And we also support people 24/7. So we're really trying to help people stay in place and do well living with their serious illness. And part of that really is to have ongoing goals of care and advanced care planning conversations. When COVID-19 hit in March, we rapidly went from in-person to, we were about, I would say, 2/3 in-person and 1/3 telephonic. And we went to totally telephonic at the beginning of March. And it actually was a very smooth transition because we had the technology to do that. And then shortly after, started doing and testing telehealth visits. And so we have kind of both of those things going on between telephonic and video visits. And when I think about an advanced care planning conversation, there's kind of 4 areas to think about. One is, how do you kind of prepare for the conversation so that it's going to be successful? And then deciding what type of technology will work best and what people are most comfortable. So I'll build a little bit on what Bonnie was saying earlier. And then the third thing to think about is, I'll share some challenges and successes that we've had. And then lastly, I think but probably the most important is the flexibility, what you were saying, Carol, is how do you switch things up on the fly? Because it doesn't always turn out the way that you had planned. So thinking about getting the conversation going, the planning for that is thinking about how you're going to prepare that person. And so it's really important to tee up the conversation. And we visit our individuals probably monthly. And so it's really important to tee up the conversation so they actually know that our visit will be focusing on that specifically rather than a whole person assessment. And by doing that, we tee up that we're going to send them out a packet of materials. And based upon what you think they're ready to see and what would be helpful, is we send out a prep letter explaining all the things that we're sending. And some of the things that we send is the pre-visit questionnaire that's available through Next Steps and Advanced Steps, decision aids, the medical priorities and treatment options handout for Advanced Steps. We send out blank advanced directive documents and POLS forms so they can read along with us. And then for the next steps conversation, what we think might be the appropriate statement of treatment preference form. In addition, we send out a self-addressed envelope so that as we're finishing up the conversation and their readiness to complete a document, we have a way for them to return and send us a copy, which is probably the hardest loop of the workflow to get the documents back. And so that's kind of some of the things to think about. The other thing is, because of technology, telephonic is pretty easy. You just call them and you have an appointment set up for that. But for the telehealth, we have put quite a bit of work into how to prepare for that. And so each one of the clinicians has their own email with their own video link that we put up with instructions on how to actually get connected to technology. And so that is sent out to the individual and family members, and whoever's going to attend would get the email. And then we also take time to have resources reach out to the individual and whoever's going to attend the conversation to help them get connected. And it's either the day before, or we have them connect a half an hour, 20 minutes before, so that when the team is ready to start the visit, we don't have to troubleshoot technology right away. So the second thing to think about is, well, what kind of technology do you use? And I think there is a certain level of receptivity to whether people want to do telephonic or video visits. And the video visits we have seen are more amenable to individuals when they have their children present. What we found is that the elders, and most of our people are 65 or older, they do have internet, they have emails, but they've got an old desktop computer without a camera, or they haven't opened up their email for a year and they have 300 emails they have to go through, or they can't even get into their email. So I think those are some of the challenges, is that elders lack the technology, or they have old technology, and it makes it more difficult. So really, telephonic versus video visits, I think you can be more successful when you've got someone that is a little bit more tech savvy that can help support them. The other thing is to think about from a telephonic perspective. We have found during COVID that people are just starved for interaction. And so telephonic has actually been working out very well, using current communication skills that you get through training, you can have a very successful conversation over the phone. People are amazingly, they're willing to share even more than I've seen actually from in-person visits. So it's kind of a nice added bonus. The other thing is to think about, from a technology perspective, privacy considerations, and how do you meet the intent of HIPAA, and understanding through what kind of policies you're going to have to really meet up to and achieve from a HIPAA standpoint. Currently, we're using Teams, Microsoft Teams. It has its challenges, but we're also looking at other platforms really to use long-term, and things that we're considering as we meet with the different vendors are options to share screens. There are some options where you can actually doodle and show people things, or edit documents or share documents, which really would be a win for teaching as well as sharing advanced care planning materials, and assist with the completion of documentation. Some of the other things to consider that is more of a challenge is making sure that whoever's attending knows it could be a longer visit. So an hour-and-a-half phone call. The other challenge is actually getting witness signatures and notary completion on documents, especially during time of pandemic. We have on some occasions gone to people's homes and stood on the front porch to notarize, but it's not ideal. And then I live in Minnesota, and so with the George Floyd issues that have come up, and during the time of the riots, a lot of our patients, they didn't have a bank or a post office to go to. And so trying to think creatively how you can do that final part of your advanced care planning. The other thing, Bonnie, I think you mentioned this, is giving people time to practice. Time to practice using the technology so that it feels more comfortable. You're not focused on technology versus a conversation. And then the importance of having resources to help schedule the visits and troubleshoot the technology is really important, which kind of brings it to that last topic, is flexibility. So you might start out with the intention of doing a video visit, and they can't do the technology, and you just jump back on the phone and do it telephonically. It just needs to be kind of that easy to switch without feeling like you're getting tripped up, that it's not going like you thought it would. And the other thing is that we really, having our palliative care service doing monthly visits, we have found that the conversation is very tolerable over several visits. So we typically tee up advanced care planning, kind of do that beginning introduction part of the conversation guide. And then we might have a physical assessment, a visit focused more on the physical and exploring kind of a whole person exploration. And we embed the exploration questions into our regular everyday visits. And then we could possibly and potentially schedule more of a goals of care conversation. And so for us, it has been a natural progression to be able to integrate various parts of the conversation over several visits. Or if you do have the time and family is willing to do it, ideally we can get it done in an hour to an hour and a half over the phone. So I think that's some of the things to think about from a flexibility perspective.
Yeah, that's a great example of how to truly integrate the principles of person-centered care and not think of it as a standalone appointment that you need for a conversation, but that you whittle away at it over time and it becomes just part of good healthcare, which is, I think, the goal. So that's awesome. I have a question. I'm curious, when you were mentioning whoever's going to attend the conversation, when that's a video visit and you may be sending links out to several people that will be attending, have you, in your experience, observed maybe, or what, I won't give you options, but what has been your observation in how many family members are then able to attend and participate in a conversation as compared to having to be physically present all at an office in one location to participate?
this last week I had 2 different visits, and one visit we had 3 sons and the patient, the social worker, and myself. So it was 5 different screens up doing the conversation. And then we actually had the home care. This person was just home from the hospital. And so we were actually able to converse with the patient because the OT from home care was there and made sure he got set up for his visit. So it was really an ideal conversation.
Get everybody on the same page.
On the same page. And then we had another one where the husband and wife and then the son and the daughter-in-law were at home with them. And then we patched in the daughter who lived in the next city, and then the social worker and I. So it works ideal. And it's amazing how people really, I think they really develop a level of trust and respect for the care that we're doing, to the fact that they took the time for us to have a conversation and they feel included. Mm-hmm. So it's amazing how they feel included.
Mm-hmm. Yeah, it'll be really fun to see how many, out of necessity, how many barriers we're finding that we can eliminate through delivering the conversation in a different way that may stay as a best practice, regardless of when we get to be together again. Right.
Well, and it was interesting with us doing telephonic work and not always seeing the people in their home. We can see their home, we can see what their environment is, and the worries, what concerns, worries, and fears question in the conversation. That family that I talked the daughter was remote, and then the patient and wife and the son were in the home. Mm-hmm. We actually addressed their concern about driving, concern about them not getting help for chores at home. It was just amazing how we were able to talk about really tough issues that the kids have not been able to bring up. Yeah. And it was just a natural process for them. So it was a great experience.
Thank you. So we've talked about adapting and preparing for a conversation, having the conversation and being nimble. Chris, can you talk about how your team has created really practical tools for follow-up after a conversation to help complete documents and documentation?
Absolutely. My name is Chris Brenneman, and I work for a not-for-profit community-based health system. We have 10 hospitals and multiple primary care and specialty care physicians. We also have convened some community partners in ACP in our community. We have a population of about 850,000 that we serve in our area where I live. I think the 3 messages that I want to talk today are about leadership matters. You hear that repeatedly in Respecting Choices, and I will share with you how that played out for us in our flexibility in figuring out what happened. The need to educate your facilitators about the new processes and how you can implement things that you typically done by passing papers when you're no longer passing papers back and forth. So for me, the journey really came to a head when I saw an NBC News story about this woman who had lived through cancer, had had a hysterectomy, had had a mastectomy, several other health issues, and she really wasn't motivated to have her ACP conversation until news about the COVID-19 pandemic came to light. And that was her motivation. And when I shared that with leadership here at Parkview, you could see the little aha lights go on, that people were understanding that we needed to be doing this kind of work now. We just needed to alter how we were doing it. And so what ended up happening is a series of successes in getting leadership buy-in into a new flexibility of offering ACP. And that was from our VP of Virtual Health, helping us to identify how the leniency in the federal privacy provisions came into play and how we could incorporate that into practice. With our corporate counsel giving us the okay to do things via email that normally we would not be doing, and just really getting those leaders on board so that we knew we had their buy-in and their support to be creative in these challenging times. The nice thing that has happened is that some of these processes we probably would not have created if the COVID pandemic hadn't pushed us forward. And they're processes that aren't going to be here today, gone tomorrow, but processes that we will continue to incorporate moving forward, which has really been a huge benefit, the whole process of planning. In the end of March, we sent an email out to all of our facilitators offering suggestions on how to keep the conversation moving forward when we weren't going to be having in-person conversations. We sent them information about how to have remote ACP conversations, including sending the newly released Respecting Choices COVID-19 materials, talking about how to incorporate those into the introduction of the conversation as well as the conversation itself, whether your patient was COVID positive, presumptive positive, or a person who just needed to have their ACP conversation. We decided to give the onus of responsibility of getting documents completed. We kind of help put that back in the patient lap, where before it would be all on us to make sure the I's were dotted, the T's were crossed, the signatures were gotten. And we talked to our facilitators about how to help the individual personalize and motivate themselves to find out, okay, who can be my witnesses during this time if these facilitators can't be present with us. We sent an email that, Carol, do you have my screen share ready to pull up?
Yep.
We sent an email out to our facilitators that they could copy and paste into an email at the end of their ACP conversation. It was a thank you for their participation. It included the two most common advance directives we complete in Indiana. It included the witnessing requirements. And then we sent the request that they be emailed back to the advanced care planning department. So once they were, we could go ahead and add them into the electronic medical record. We gave them our physical mail address, thinking that could be an option also. And then we also attached a satisfaction survey to that email. So the facilitator just needed to copy and paste it. You know, Respecting Choices talks about common, consistent, repetitive language. Let's all use that same email, that same language, and put it out there. So we helped to create that and get that right out to facilitators. One of the things we did do a quick process adaptation on was those returning of the documents. So sending them back via scanning an email wasn't always an effective means for a person. Actually snail mailing them back in their own envelope didn't work. And so we started sending self-addressed stamped envelopes that they could just pop the copies in, send them to us, and they'd come right to the department so that we could get those scanned in. The other thing that was really important to us is to make sure our facilitators used a cheat sheet. So how do we help our individuals know that they were accurately completing documents? And Carol, if you would show what we ended up doing. We ended up marking up actual documents to show the individuals. The highlighted spaces are spaces where you have to put in a piece of information. And then if you'll scroll down a little bit, Carol, then we put the details. So the representative must be over 18 years old. This is the section where if you name a secondary representative, this is where you can fill in that information. And not only do we send them the blank advance directives, then they get this cheat sheet. So if they're the ones who are trying to get the witnesses, they're going to be able to get valid documents witnessed. So when they come back, we know that we can scan them in and they are correct forms. The final thing that we did was really reinforce the value of continuing to do satisfaction surveys. we want that data. We want to be able to show the continued value of ACP, and we really wanted to look at how that might have changed between doing in-person conversations and remote conversations. So I ended up looking through some data to see if I had anything I could report that can be of value today. And I looked at survey return rates from March of 2019 to March of 2020. We had an average return rate of our surveys of 33%, with a high, we had 54% 1 month and a low of 22% in that 12-month period. In April of 2020, we had a 13% return rate, so obvious decrease in our return rate. We decided to make the survey available via SurveyMonkey. So instead of having to complete a physical survey, we put Respecting Choices survey on SurveyMonkey. And even though in May we also only had a 13% return rate, 60% of that return rate was related to the SurveyMonkey. So we had success in just giving them that quick link in order to be able to complete the survey, get that back to us, give them that self-addressed stamped envelope so that, again, they could get that back to us and we could make the process as seamless as possible.
Nice. Thank you, Chris. Bonnie, Sandy, anything that you would add about lessons learned from your experience in following up or sort of closing the loop at the end of a conversation?
Well, I have found in my experience recently, it's always been true, but even more so now that, you know, sometimes I'll get questions that I can't answer, that there's a lot of legal nuance. And I recently did a conversation via Zoom for a couple, and they sent me all of their documents and 3 pages of questions. So prepare for people to maybe be even more prepared. But, you know, I relearned the value of, even if I don't have the answer and I say I'll get the answer, just checking in again, even if I still don't have the answer, and just sort of saying, hey, just touching base, letting you know I'm having my legal department look at it, or whatever the issue is. I find that that's valuable, and it helps maintain that trust that you haven't dropped something that is so important to them, that you haven't just forgotten about it.
Yeah, great, thanks.
Oops. I guess I would echo the importance of that follow through and trying to get the documents back. I guess that's the toughest part that we've had, is completing the loop and actually getting completed documents. And we have not tried the email route. I'd be interested to ask you, Chris, about privacy and what kind of things were considered around email and emailing the healthcare directive via email. Any insight into that process?
Yeah, so like I mentioned, we did connect with our corporate counsel to make sure where we stood with things. And what we ended up doing as part of our conversation beginning disclaimer is to say, even with the leniency of the federal rulings, that we could not guarantee HIPAA compliance even over a phone call, or not being Zoom bombed, or even via the email. And we asked the participant whether or not they wanted to proceed with the conversation, knowing those potential risks related to privacy. So we gave them the ability to have an out anywhere along the process that they might feel not comfortable with privacy or perceived lack of privacy in the process. So again, we put the onus of them deciding what they were comfortable with and following through what was consistent with what felt right to them.
Yeah, nice. So I guess, Chris, I have a question for you. I know that in some of our prior conversations, you were reflecting on some of the differences to think about when offering a group advanced care planning activity as opposed to individual ACP conversation, when either one are being done remotely. We've been focusing pretty much on an individual conversation remotely. What's different when you think about planning for a group ACP activity?
Yeah, I think there are several things, but maybe three main thoughts that we had. One has to do with that practical consideration of how you get materials to the people who are participating in the group. And when you do that, do you send things pre-conversation? Do you screen share during the middle of the conversation, or do you send things post-conversation? So really trying to decide what makes the most sense given the group that you're interacting with and their access to the materials and what makes sense for that. We always in group conversations use that turn to your neighbor and talk about whatever that might be, and now that opportunity isn't there. And so I think being willing as a facilitator to set the stage that I may ask one of or two of you to tell me what that looks like, what's a good day look like, who would you be spending it with. If no one comes up, I'll even preface and say, I can see all your names on my screen, so I may ask if no one volunteers. Or also setting the stage if you have 10 hands go up and 10 people want to share, setting that stage so that people know what to expect. And then one of the things we're looking at is at the end of a group conversation, we always offer the opportunity to sign up for a one-on-one. And we're looking to see if there's any impact between motivation if you've attended an in-person group session versus motivation if you've attended a remote group session. And that's a work in progress, but I might have some details on that in the future.
Awesome. Thank you. Bonnie?
Can I just add to that?
Absolutely.
So I have found that, you know, even if people have the documents, I still use that chat box as a place to put links to. Well, we have our own advanced directive that we've written, so I can provide a link to that. I can provide a link to some micro-learning videos that we have. I have ways and tell them how they can save that chat box if they really want that information, or they can click on it and save it to go to later. And then, you know, that turn to your neighbor thing, I think is so critical as part of the group experience, because you start feeling like you're not alone in the boat. And so one of the adaptations that we've made is one of my standard questions throughout whenever I present to a group is, so what brings you joy? It's a way for me to set up how easy it is to do advanced care planning, and that it can be a joyful thing. And I ask people if they feel comfortable to just write again in that chat box. And I can monitor that chat box, and I can go back to the examples of like, oh, I see a number of you say gardening and cooking is important. So it sounds like independence to a certain degree might be really vital to you. And it's a way to call out people without calling them out. And it's been helpful to me to also see where I might need to provide specific examples of outcomes that ties to what brings them joy or what their preference is.
Great. Good observations. Thank you. So I think the one last question that we'll have time for, that I'll ask all of you to chime in on is, how can what we've learned in this time highlight issues of equitable access to advanced care planning? So what have we learned that can either help address, or have we learned things can actually worsen barriers to advanced care planning for those who may struggle with access to healthcare services and or advanced care planning? So Bonnie, you want to kick us off?
There we go. Yeah, I think one of the things, of course, is you know, if we're doing virtual stuff, recognizing that even though it's a utility, it's not a utility yet, and so that there might be a digital divide there. I also think that you know, we think about Black Lives Matter and what's going on at the same time as COVID. We recognize that COVID is hitting Black, Indigenous, and people of color much more strongly than whites. I think it's incumbent upon us to look at and research some of the barriers that they might encounter and getting the care that they want. So I think it's incumbent as facilitators for us not only to have that conversation and help people to explore what their values are, but help empower them to take those values and preferences and make them real. I really like the idea, as Chris was talking about, of helping people sort of own those pieces. And so, for example, for me, as a facilitator, I learned about, how pain management really is racist in practice, and how even some hospice utilization comes out to be unequitable. And, knowing that, I feel like there's a duty for me to help those people who are Black, Indigenous, and people of color recognize that that's part of the system issue. And how can we move beyond that? How can they get, like, maybe I'm talking about what their advocacy rights are, or how can we provide language that's unequivocal in its clarity? Things like that I've taken to heart lately.
Mm-hmm. Yeah, well said.
I guess I would add something from disparity or equity from geographic perspective. Because of the normalization of telehealth and telephonic work, the pandemic has really pushed us to really figure it out. And I think that we have an opportunity to actually increase the access to resources for advanced care planning and having conversations. And it doesn't matter where you live. Mm-hmm. If you have a telephone, you can have the conversation, and that it is doable to do that. And so that's one thing I think from a geographic perspective. And then the other thing from a rural community, obviously there are not as many resources to have the conversation, so it actually it increases the access to advanced care planning resources. But then also in a rural community, you may not have a neighbor that is able to witness, or they're not able to travel to a bank to have it notarized. And so one of the things that we're looking at is, how do we do remote online notarization? So because most of our work now is going to be telehealth or telephonic, as we spread to the state of Minnesota, we're really trying to figure that out to ease that 360 process.
Mm-hmm. Nice, thank you. Chris, anything to add?
Yeah, I think, when we train new facilitators, we always talk about remembering the value of the conversation guide and trusting the process. And I think that plays out completely in remembering that living well or quality of life can only be defined by the individual, that it's not a judgment I can make on their behalf, or that any other healthcare professional can make on their behalf. And as facilitators, if we model and educate and incorporate this into our practice and help others incorporate it into their practice, that will help us mitigate the likelihood that healthcare decisions will have discriminatory impact based on assumptions, because we're going to ask and we will know.
Mm-hmm. Understand what matters most before we ever enter into any decision making.
Exactly.
Yeah, that's person-centered. Awesome. So I want to thank all three of our panelists for helping to share best practices of all of what we've learned during the crisis, but I think a lot of what we've learned, as we've talked about today, will serve us and those we serve very well into the future. So thank you all again. And on behalf of all of us, we hope those of you who are watching learned more than a thing or two. So thank you again very much.
Thank you.
You're welcome.